Assalamualaikum doctors. In this video I am discussing orbital cellulitis or periorbital cellulitis video stations. Also same the management of history. So in history description we find that a child eye swelling, and it is maximum cases unilateral eye swelling. If the child can open the eye, able to open the eye, we go periorbital cellulitis, but this child is cannot open the eye, so it is orbital cellulitis. Also there are some feature point. We comment that any medicine device attached or not, these are. So orbital cellulitis, it is an unilateral eye swelling. The differential diagnosis we can keep: orbital cellulitis, periorbital cellulitis, conjunctivitis, trauma, sting bite, allergy, eye infection secondary to facial palsy. We can tell leukemia, retinoblastoma, lymphoma, neurofibromatosis. So again, the DD of orbital cellulitis, it is an unilateral eye swelling. The DD are orbital cellulitis, periorbital cellulitis, conjunctivitis, trauma, sting bite, leukemia, retinoblastoma, neurofibromatosis, eye infections, allergic reactions. So the history of orbital cellulitis we are asking: onset, course and duration, what increase and what decrease, is there any diurnal variations? Eye symptoms, that is symptoms: is it red, painful eye movement, affection of the red and green visions, excessive lacrimation, oozing pus, any bulging eye, light intolerance, is it affecting the upper and lower lid or both, any proptosis or chemosis, then any swelling in any other part of the body, where it started, any associated with fever, headache, sign of increased intracranial pressure, any drowsiness, seizure or abnormal movement. Then any recent any dental procedure, is it preceded by sinusitis, any history of trauma, sting bite or anaphylaxis, any family history of similar condition, any chronic illness like nephrotic syndrome, diabetes mellitus, immunodeficiency, and any drug he is taking. So the history are onset, course and durations, what make better and worse. Then eye symptoms like is it painful, is it oozing, any pus present, is it the eye is red, any problem in visions, problem in eye movement, lacrimations, these are, and any green and red color differentiations. Then we can ask anywhere, any part of the body, any swelling, any history of any trauma, sinusitis, dental teeth extractions. The child is suffering any chronic conditions like diabetes, nephrotic syndrome, immunodeficiency, any allergy to sting bite. Then we can ask family member has similar conditions, any drug history, these are. And also the fever, weight, activity, sleep, shortness of breath, headache. Examination, first of all I will do the after involving my consultant. So orbital cellulitis is an emergency, will involve the consultant, very important line. ENT, ophthalmologist, neurologist, if needed, neurosurgeon, ABC vitals, consciousness level, general examination for sign of sepsis, eye examination, ENT examination and neurological examination. So we involve the consultant, ENT, ophthalmology, neurology, neurosurgeon, and ABC vitals we are seeing. Then we eye examination we do, any sepsis present, ENT examination we do, and neurology examination. Then what are the investigations? So it is sepsis, full blood count, CBC, ESR, CRP, culture sensitivity. Then CT or MRI of the brain if needed. Then other swab from the eye if possible. Indication of CT if asked, that suspected orbital involvement, central neurological sign, inability to assess the eye movements or visions, bilateral edema, deterioration despite treatment. Indication for MRI, suspected intracranial involvement of the CT. What are the complications? Complications are, first of all, eye orbital abscess, optic neuritis, blindness, exposure keratitis, glaucoma, panophthalmitis, neuro or cranial nerve palsy, subperiosteal abscess, meningitis, cavernous sinus thrombosis. So orbital abscess, facial nerve palsy, vision problem, glaucoma, panophthalmitis, meningitis, cavernous sinus thrombosis, these are problem. Then management is very important, multidisciplinary team, antibiotics plus red flags. So periorbital, review the eye movement and red-green color vision. So review the eye movement and red-green color visions. Orbital, urgent ophthalmology ENT review within 4 hours for surgical drainage. So orbital cellulitis is an urgent ophthalmology ENT and neurology review. It is an emergency. Intracranial complication, urgent neurological review. So treatment of orbital cellulitis is that we start ceftriaxone or cefotaxime IV. If toxemic, add the clindamycin IV. If penicillin anaphylaxis, ciprofloxacin plus clindamycin. If penicillin allergy, clindamycin. If improving, shift to amoxiclav. Duration is 21 days and 6 weeks bone involvement. So orbital cellulitis we are giving IV ceftriaxone, and toxic clindamycin easing, clindamycin adding, and if allergic, that's ciprofloxacin and clindamycin. And shift to co-amoxiclav once improved, 21 days is duration of the treatment, and 6 weeks if not, if bony involvement. Now about the periorbital cellulitis, we give upper eyelid only co-amoxiclav. Both eyelid and severe no improvement after 48 hour co-amoxiclav IV. If penicillin allergy, clindamycin. If improving, shift to co-amoxiclav oral, and duration is 14 days. So about the orbital cellulitis, periorbital cellulitis we are giving if serious case not improving after 48 hours, then it is IV co-amoxiclav, or otherwise we give the oral co-amoxiclav. If we start with IV co-amoxiclav, when the patient is improving, we give oral co-amoxiclav. And if the patient has penicillin allergy, we give the clindamycin. Duration is 14 days. So indication for admission is suspected orbital involvement, fever, immunocompromise, no improvement after 48 hours of oral antibiotic, less than 1 year. Sinusitis, if acute, treat it with amoxicillin orally, change to amoxiclav if no response after 48 hour IV if severe, total 7 days antibiotic. So different is I am telling orbital and periorbital. Periorbital eye can be examined where orbital unable to examine. Periorbital is that facial erythema and tenderness. That is, orbital is painful eye movement. And ophthalmoplegia. Periorbital normal eye movement where orbital pain and tenderness. Periorbital normal visions. Orbital is visual impairment. Red-green color differentiation lost early. Periorbital preceding superficial trauma and orbital preceding sinusitis. So sinusitis is orbital cellulitis. Periorbital eye pain where orbital is proptosis, chemosis, pupil or fundi abnormality. Periorbital there is periorbital swelling, but orbital there is decrease the Glasgow Coma scale and headache. And periorbital may be low grade fever but systemically unwell and toxic in orbital cellulitis. So this is all about orbital cellulitis video station and history management portion. Thank you.